Thinking about another biomarker, though, that everyone was so excited about a few years ago, and still very elegant work, and I commend the team for doing this. But the AR-V7 story, where does that stand today for you, Neil? Are you thinking about testing? There is a test that's available. What are you doing?
Yeah, I use the AR-V7 outside of trial work, but from a practical standpoint, if I have a patient who is progressing on an AR inhibitor, typically AbbVie or Enza, and they say, I really want to do, I don't want to go on to chemotherapy, or I don't want to do something, for whatever, the radium or CYP-T, and they're really kind of pushing that because they like the idea of an oral therapy. I will use it there for sort of an equipoise way to say, well, but here, you have the V7 and it's really not going to be of any benefit to you. But generally, I'm not a huge proponent of it because based upon the switch data that we've already discussed, based upon the fact that there are other really good therapies with different mechanisms of action, and then also we did the ARMOR trial, which we were looking at galaterone, and we were trying to find all these patients who had AR-V7. And as we all know, it's a very small percentage of patients, and they progress so quickly that have that primary resistance to an AR drug. You kind of see them. They're phenotypically so aggressive. They progress so dramatically quick. So I haven't really found it to be, other than outside of some trial work that we're doing, clinically relevant in my practice.
And what about you?
Yeah, similar. We kind of all thought we were going to use it a lot, but again, I think once the patient starts failing one AR inhibitor, we pretty much know they're not going to do well on the other. So we really haven't used it very much at all. Plus, it's not an inexpensive test. So what are you going to do with it? It's a small number, so we really haven't used it much at all anymore.
And Jorge?
So 2 points. Number one, I think for the switch, I think splice variant is irrelevant. I think the CAR data, to me, proves the point. I think the question is, if I see I don't use it, by the way, and I don't use it for the same reasons that you gave, Neil. I think the bigger question is, if I see a patient who comes with a splice variant 7, is positive, and he's just developing castration-resistant disease, and the patient asks me the question, well, I'm on ADT alone, oral therapy or docetaxel as a front line. So if I were to see that splice variant with the Antonio Carr's data, I would say, maybe I want to lean towards chemotherapy because the likelihood of you benefiting to an oral agent is going to be low. But the splice variant is also volume dependent, which means that if you treat disease, doesn't mean that you cannot ever get an AR inhibitor. And although we talk at length as to the importance of sequencing, layering, I would argue that if I'm the patient, I want to get exposed to all the treatments that are life-prolonging in nature, and I would defer to my doctors to layer them or use the ideal sequence for my case, but I want to get to be exposed to all of them. And the question is, how do you do that? So if I see a splice variant up front, I may pick chemo over an oral agent, but it doesn't mean that you cannot come back and get an oral agent later on.
I think you make a great point. I think we're all totally committed to this, the theme that, look, this is a terminal disease. Unless the patient dies of a cardiovascular event or something else that's non-prostate cancer related. And so at the end of the day, when the patient succumbs, you want to make sure that they were given all of the approved therapies, and then ideally a fairly important trial, unmet need, unmet combination. And we do that. I'm sure we all do this. And when these patients who've been in our clinics for years succumb, you want to basically go back retrospectively and say, did I sequence optimally for this? Did I give them the best chance?